Hello and good evening, everyone. It's welcome back to our webinar tonight. My IVF. We are back, of course, with another topic, and as you can see, we have another special guest. Dr. Laura García is right with us. Of course, she is in Madrid at the moment, and we are happy to have you back. So last time we spoke, we were talking about other topics. Of course, we were talking about, if I remember correctly, advanced maternal age. Tonight we will focus on genetics. So I'm very happy to be back with you. Dr. Garcia, how are you feeling tonight? Welcome back.
Very well. Thank you so much for this webinar, and I hope everything has a good evening.
Exactly. So please remember that we will, of course, start with the presentation. Dr. Garcia has prepared two cases based on, of course, on genetics, and she will discuss what was diagnosed. She will discuss what protocols have been used, and of course, she will explain how the clinic, of course, and she was able to get that final result, positive result, of course, as well. And afterwards, as always, there will be time for your questions. So don't forget, you just need to type those in the chat section. And of course, Dr. Laura will definitely answer them for you. So don't hesitate. I know that this is always the favorite part of any patients, because of course, that way you can ask your own question, get some more advice. So don't hesitate. Okay, we are here to support you. We are here to help you out a bit. And as you probably, if you haven't seen some of the webinars with Dr. Garcia, I am sure that she will be able to help you even a little. So just go ahead, just do it. Okay. And of course, remember, it is going to be recorded, so it will be available next day on our platform, My IVF Answers. And let me just mention that we are part of European Fertility Society, and we are here. This time we are focused on success stories. And as you probably have seen, there were some previous webinars also on genetics, but we are definitely only focusing on the success stories, on the real life cases. So I think this is always something that patients always look. It's always inspiring for them. Yeah. So no matter what happens, you can always find something similar to perhaps your case. And that's why we are here. We just want to show you as many as we can. And yeah, that is it from me at this point. Okay, so let's go ahead with our presentation. And let me just mention that if I haven't, I think not, Dr. Garcia, she is the medical director at Clinica Tambre, located in Madrid. And yeah, let's go ahead with the presentation. Okay, I'm really looking forward to it. And of course, remember, there will be time for your questions, which you can ask in the chat section. Thanks so much. Let's go.
Thank you, Caroline. Okay, so let's start with this case of patient with genetic issues. Okay. What we'll cover during this presentation, first we will introduce the clinical case, so general description and situation. Then we will have an introduction and first steps, the first results, the treatment, how was the embryo transfer, the pregnancy, and the conclusions. So let's review the general description of the case. It is a female of 33 years old, 47 kilos, 160 meters, so normal BMI, 18. Personal history, nothing relevant. No toxic habits, no known allergies. One sister, healthy, with 2 healthy children. The parents with no known pathologies and no previous IVF cycles. She had 2 pregnancies with 2 abortions. Her couple is 35 years old, normal weight, normal height. So personal history, no toxic habits, no known pathologies, no previous surgeries, healthy parents, 1 sibling with no children yet. So no previous children with other couples before. So both as a couple had 2 natural pregnancies, one with intrauterine fetal death due to multiple bone malformations, it was an induced natural childbirth without complications. And the second, also natural pregnancy, ended in a fetal death at 22 weeks of pregnancy and also multiple bone malformations. They come to our clinic because they were afraid of a new natural pregnancy, of course, and they have not undergone genetic testing because they have been told in their countries that it might just be bad luck with these two pregnancies. But they wanted to know if we could help them because they were, of course, afraid to go ahead with another pregnancy with the same risk. What we recommended is to do the genetic carrier status test and also the PGTA of the embryos. This couple had no genetic testing before, had no genetic counseling, had no tests in these two previous babies born. So what is the carrier screening status test? We are doing the ARES that offers sequencing of and deletion duplication analysis for a number of genes, over 300 mutations. And this is a test where we do to the female and to the male to see if they are carrier of any recessive mutations. What is PGTA? What is the testing of the embryos? So we do with next generation sequencing to read the DNA code of one several genes, okay, on a base by base basis to determine the genomic sequence of an individual. So for each embryo, we are going to test the karyotype with next generation sequencing to be sure if they have any chromosomes disorders. What were the first results? So as a result, we found that both are carriers of an autosomal dominant mutation, very specific, which is glycine substitution in COL1A1 or COL1A2 gene, which results in a significant defect in the production of type 1 collagen. Collagen type 1 is a structural component of the extracellular matrix of connective tissue, whose function is to provide support of tensile strength to tissues. This protein is most abundant in bone and skin. And this mutation, when is for this when is affecting, it leads to osteogenesis imperfecta syndrome. That was the problem of these two babies. So the osteogenesis imperfecta syndrome is colloquially known as brittle bone disease, and osteogenesis imperfecta is a rare disease due to its low incidence. It is 1 every 15,000 babies born, or even 1 every 20,000 newborns. It affects both sexes, races, and ethnic groups equally. And it comprises a group of diseases caused by heterogeneous disorder of the connective tissue. It can cause hearing impairment, dental, and pulmonary abnormalities. So after learning of this genetic alteration in both of them, we had to do an IVF cycle in order to obtain embryos in blastocyst stage to carry out the PGT on them, the pre-implantation genetic diagnostic. New tests show low ovarian reserve in her and asthenosospermia in him, as well as a DNA fragmentation of 20%, making it suitable for normal ICSI. So what is ICSI? The treatment. The intracytoplasmatic sperm injection is an IVF procedure where a single sperm cell is injected into the cytoplasm of an egg. So in this case in particular, because of the problem of the sperm, which is called astenosospermia, which means the mobility of the sperm, it's not in the normal range, that should be at least 32% of sperm mobiles, but this had only 20%. And also when we're doing pregenetic diagnostic, the ideal is to do ICSI. And why is that? Because we want to exclude other sperm in the external of the embryo, which means that we are more specific in the results of the embryo and not obtaining results, genetic results of the sperm. So, as I said, we did IVF ICSI. As long as she had low ovarian reserve, we did 2 rounds, 2 cycles. The first cycle was a duration of 10 days with dual trigger. So she had 6 eggs, 5 mature, 5 were fertilized correctly after ICSI, and we obtained on day 5 2 blastocysts AB and blastocyst BA. And we did PGTA and PGTM. PGTA is to be sure about chromosomes problems, and PGTM is to exclude babies that were affected with the osteogenesis imperfecta with this mutation. The second cycle, after a month's break with Jasminel, we did also a dual trigger, which means we used 2 medication to make the maximum eggs retrieve mature, and we obtained 7 eggs, 6 matures, 3 fertilized after ICSI, and again we obtained 2 blastocysts, also good morphology, AB and BB, and again we did PGTA and PGTM. What were the outcomes of these 2 cycles in the genetic testing? So we had from the first cycle 1 aneuploid blastocyst, which means had 1 extra 23 chromosomes, and we had 1 less chromosome 11, a monosomy of 11 and a trisomy of 23, and a carrier of the disease, which this embryo needs to be excluded, of course. Then we had the second, which was 1 euploid blastocyst. It was not a carrier of the mutation of the disease, so it was healthy. The second cycle we had, the result was 1 euploid blastocyst, not carrier, and the second again was an euploid blastocyst with a trisomy for chromosome 14 and carrier of the disease of the mutation. The clinical case of the embryo transfer, we did for the first endometrial preparation for the first embryo, treatment with estrogen, with Progenova, 6 milligrams per day, and progesterone, 400 milligrams ultragestan every 12 hours, 5 days prior to transfer. We did embryo transfer with abdominal scan monitoring, and 11 days later, we asked to do the pregnancy test in blood tests, and unfortunately, it was a negative result. You can see here in this image where we use the catheter and we leave the embryo inside the uterus. It is a very easy process with no sedation needed, and you only need to rest for 20 minutes, and you can do normal life later and only avoid sex and exercise for 3 days. So it was very sad because we only had 2 embryos, and with the first, it was not successful. And it is very dramatic and very frustrating when people was okay to have babies, so natural pregnancies, but then we do embryo transfer and it is not successful. So of course they were very disappointed, and also we were very frustrated. So we decided, before going ahead with the second embryo transfer, to do endometrial testing, which is a test that really analyzes endometrium. And as long as she had 2 previous natural pregnancies, we decided to do this endometrial testing in a natural cycle, which means monitoring the ovulation, monitoring the follicular development. And once the endometrium is ready in terms of thickness and we're ready to ovulation, we do the trigger of the ovulation with Ovitrel, we add progesterone, and we do the biopsy. Endometrial is a test where we use 3 tests including in this endometrium. That's because of endometrial trio. So the first is the area testing to be sure about the window of implantation, which means be sure exactly the ideal moment for the transfer. And in that case, it was revealed that it was receptive on LH+7, which means normal window of implantation. For the ALICE, the second test included in the endometrium, there were no infections. And for the third, the microbiome called EMMA, it revealed dysbiosis. So there was the recommendation of probiotics. So before going ahead for the second embryo transfer, we recommended doing treatment of 15 days of vaginal probiotics. As I said, the endometrial preparation, we did natural cycle using Ovitrel and progesterone, 400 milligrams every 12 hours, 5 days prior transfer. Again, embryo transfer with abdominal scanning. And fortunately, this time we had a positive result and ongoing pregnancy. So we had an ongoing pregnancy that ended in a delivery at 40 weeks and 3 days, vaginal delivery, and the baby was born with 3 kilos and 200 grams. So as conclusions, we can say that it's extremely important to talk with patients about PGS and the carrier status testing, and also the need of natural cycle for embryo transfer if previous natural pregnancies have been achieved. So thank you so much. And of course, I'm open to answer all questions regarding this case or regarding other possible cases.
Excellent. Thank you so much indeed for showing us this as well and explaining how it started and, of course, with the end of it as well. Yes, and now it is your time for your questions. So go ahead, type those in, anything that's on your mind. We are here to help you out. And, of course, Dr. Garcia will definitely will be able to provide you with more details. And there is one question already from Melissa. Let's have a look at it, of course. Let's get it started. When is PGTA recommended? Is it recommended in all patients of advanced age? What are the current guidelines?
Thanks a lot, Melissa. So PGTA, yes, it's recommended specifically in women with advanced age, which is considered, depending on studies, 38 years, 40 years, also with previous rounds of IVF that was not successful, and also with patients with previous miscarriages. Then, of course, depending if karyotypes are abnormal, we should go ahead with PGT-SR, which is kind of PGTA, but is to be sure if there is any problems in abnormalities in chromosomes and also translocations.
And thank you, Melissa, for your question. It's definitely good to know. And thank you, Dr. Garcia, for answering this one. And let's have a look. We have another question. So Lucy has added some things here. We have got 2 cycles, 5 oocytes, 12 embryos. PGTA, unfortunately, none was good. Woman has translocation balance with 7 and 8. Anything you can advise?
Yeah, so I'm so sorry. Yes, with translocation, it's very, very difficult to achieve normal embryos. It's around between 15 to 30% of possibilities to find good embryos. But of course, they had 12 embryos. So I would say before going ahead, not only consider the translocation, but perhaps also check if the fragmentation has any problem, okay, that could also increase the risk of abnormalities, okay, because with 12 embryos, with the percentage that I said, it should be feasible to find a normal embryo, euploid embryo.
All right, Lucy, thank you so much also for your question. Garcia, again, thank you so much for answering this question. Okay, Melissa has added one more. Does genetic testing really increase pregnancy rates in older women?
That's a very, very good question, Melissa. So what we can say is that comparing one embryo without PGS with one embryo of PGS, talking specifically with women of advanced maternal age, it should increase pregnancy rate, of course, because imagine a woman with 42 years old, the risk of abnormalities is extremely high. By contrast, if we only focus with normal embryos, then the percentage of implantation and ongoing pregnancy is extremely higher compared with no tested embryos. So that's the reason why with one embryo tested euploid and with one not tested embryo, so we don't know, then the percentage is absolutely different. Of course, there is some evidence that suggests that when older women have not a very good ovarian reserve and have not a lot of embryos to do the procedure, we know this is invasive and this has, some risk. So probably it won't be, recommended. But of course, again, we always prefer to work and focus with only euploid embryos.
Thank you so much, Melissa. Definitely an interesting question. And of course, thank you for answering that one as well. Okay, Christina has another question. Some details are right here as well. I am 41, AMH was 3.59 picomoles in March 2020. I have done a few mild simulation resulting in 2 frozen embryos. I would like to try long protocol with diferilin on day 21 of the cycle. Some doctors recommend, others say long protocol isn't good for low AMH. What is your view on this?
Okay, yeah, it's a very good question. Thanks, Christina, for sharing your case with me. I wouldn't recommend long protocol with low ovarian reserve because it really, desperates when doing the stimulation because it really takes long time. And normally, with my experience, is that we retrieve not the same number of eggs, even lower. So I wouldn't recommend. I just recommend contraceptive pill if you haven't used that, but not long protocol.
All right. Thank you. Understood, of course. Christina, I do believe that that was helpful for you. And of course, there's a thank you from Christina right here. And let's have a minute. Okay, we are waiting for some more questions. So again, remember, if you have any left, go ahead, type those in. This is your time. But if not, of course, remember, I can assure you that Dr. Garcia and her team at Clinica Tambre will be happy to help you out on some with some consultations, etc. And I know that this is probably the best way to get some more details here. We are definitely here to help you, but if you would like to get in touch, there's always a possibility for you to get in touch with the team. And let's give it a minute. Okay, we are still waiting for some more questions. Let's give it a minute. If not, we will be finishing, but let me know if you do have more questions, of course. Okay, and let's have a second. Let's give it a second. At least at the moment, I don't see anything. Someone is typing. We need to be patient.
No worries. Of course, we
So
can
let's
take
give it a minute, of course.
time.
Again, someone is typing. Let's have a look. And as you can see, Lucy has added a thank you for you, of course, for the answering for the previous question. And let's have a look. Here's the next question from Lucy. Can you explain the fragmentation again? I did not understand well. Okay.
Sure, Lucy. Sure. So in that case, we of course have the main risk of translocation in the karyotype of the eggs. But as I said, with the good number of embryos that you had, we should consider the sperm, okay, if karyotype is all right, and also if fragmentation is good, which means that internally in the head of the spermatozoa, if the DNA is damaged, it could be also a problem of disbalancing chromosomes in the embryos. So there is fragmentation testing, not only single, but also the double DNA fragmentation, which means, again, in a sperm sample of your husband, to see in the head of the spermatozoa if the DNA has problems, interruptions, which means that we need to improve this, which means reduce fragmentation, or even we need to do specific technique in the laboratory. Or if by contrast, fragmentation and fissure of the sperm of your husband is all right, and it's only the karyotype which is the problem, so we just need to talk and decide if going ahead with another 2 rounds of stimulation and even, having more embryos, or if you prefer to change to egg donation because it's really a lot and it's really, too much for you probably in terms of, stimulation, emotional aspects, and also if success rates are not good, then perhaps it's much better to think about egg donation or going ahead with another rounds.
Excellent. Thank you so much, of course, Lucy and Dr. Garcia. As you can see, karyotype of my husband is okay.
Yeah. So even though karyotype is okay, I would strongly recommend to study before the next round the sperm, because with all this number of embryos, of course, translocation can justify, okay, because it's around 15 to 30% of embryo per embryo, the euploid embryo. So this is very, low. But with 12, it's, quite unlikely to do not be able to find at least any egg, any embryo.
All right. I'm waiting because someone is typing. I'm not sure if it's another question or maybe Lucy has something else to add. Okay, it's another question. So thank you so much, of course, Lucy, for sharing, and thank you for your help. And Melissa has one more question, interesting one again. Is PGTA recommended in embryo adoption?
So in embryo adoption, if PGTA is not already done, I wouldn't recommend, because if the embryo is already frozen, Caroline and Melissa, it would be very invasive for the embryo to do the thawing, do the procedure, okay, the biopsy. By contrast, if you ask me if it is good to, adopt an embryo coming from PGTA, which is euploid embryo, of course, it's, very good, but it's not necessary. In Spain, for embryo adoption, you can only have access to embryos coming from women of less than 35 years old, which means that the risk of problems inside, problems with chromosomes, it's low, but it's never 0%.
Excellent. Thank you so much. Definitely interesting thing to remember. So thanks a lot.
Correct.
This is definitely a field that is, not everyone is aware, that is possible. So thanks so much. Of course, as you can see, Lucy, thank you very, very much. So I do believe that it was very helpful. So thanks so much for that. And Fabiana has another question. Would you recommend testing a frozen embryo for PGTA, or is it too risky to thaw it for testing?
Correct, Fabiana. So thanks for asking this. I would never recommend doing PGTA for frozen embryos because we have confirmed in our own data that even though the biopsy is successful and the embryo reveals the normal chromosomes, then the pregnancy rate is very, very low because it's very invasive. So it's not recommended.
Excellent. Thank you so much for the clarification. And I believe Fabiana also found it useful. Thank you from her. Okay, Christina has another question. Can you please explain the protocol you mentioned with contraceptive? I was recommended just mild stimulation with gonal and menopause. Thank you.
Yeah, so Christina, to use contraceptive the month before, okay, with your previous period of, the month that you're going to do the IVF, will improve probably the synchronization of your follicles, which is the same objective as with the lung protocol. So that's the reason why probably I would recommend in your case doing contraceptive pill with the previous month 10 to 12 days, not longer, because these also can be, decreasing your response if it's long time contraceptive pill, but I think it's a good protocol for you.
All right. Again, thank you so much for sharing again, Christina, and thank you for your answer. Thank you also from Christina. And do let us know if you have more questions. There is also a thank you from Melissa for answering my questions. So yes, it might be our final question that we got from Christina. If you have more, you know what to do. You can still type those in, or if not, as I've mentioned, there is always possibility for you to simply get in touch with Dr. Garcia and team at Clinica Tambre, of course, in Madrid, and I'm sure they will be happy to help you. I'm waiting simply because there's someone that is typing, and I want to make sure that we have.
Of course, Caroline, we will happy to receive information of individual cases because we have a lot of experience with genetics. We have our in-house laboratory where we do biopsies with expert seniors with laser, and also we have our own genetic councils that will advise. So sometimes I have initial consultation, first consultation, where I can just inform that couple in particular, but then I always have a chat with the genetics before doing the second consultation to just clarify more in depth.
Oh, of course. Thank you so much for adding this. And in the meantime, Lucy has one more question. No problem, Lucy, at all. Don't worry. Is there anything I could do to get my best genetic eggs out?
Unfortunately, Caroline, every single woman has its quality. I believe it's nothing that it's it's not a 0%, so I would encourage Lucy to go ahead with another round, and as I said, just exclude other problems in the sperm that Caroline could also be unbalancing the chromosomes in the embryos, and if not, just reconsider different stimulation, different protocols, and try to perhaps do 2 rounds with the same number of embryos, and I believe she will be able to find an euploid embryo.
All right. And of course, as always, fingers crossed. Okay. Best of luck. We all wish you best of luck. And because,
All the best.
we always need to think positive and hope that it's going to work. Right. So thank you so much indeed, Lucy, for sharing. And no problem at all. If you have more questions, you know what to do. And there is a thank you from Lucy right here. So I do believe it's been helpful. And someone is again typing. Let's give it a second. We need to wait and see if it's going to be another question or a thank you. So yeah, let's have a look and see. Nothing yet, but again, I see someone's typing. So I believe it's a question because it takes a bit more time than just a thank you. So let's wait. Okay, we do have another question, and let me go right here. Thank you for your presentation. I went for an IVF procedure and 23 matured eggs were retrieved and only 14 was fertilized, but only 3 got to day 3 and none got to day 5. Is it a result of the genetic composition?
I believe no. Thanks a lot for your question. I believe it's more to do with quality, okay? So not internally chromosomes, but quality. So in that case in particular, I should, consider probably more the egg, because from 23, only 3 on day 3 and nothing to day 5, probably it's more the egg. So you should talk with your gynae, try to see if you can do some melatonin protocol to try to reduce possible problems in your eggs and antioxidants. But again, as we said, Caroline, every woman has its quality, and there's really not a lot we can offer to improve quality.
Of course, understood perfectly. So thank you so much for sharing again. And again, someone is typing, so thank you. Yeah, it's a thank you from our patient right here as well. So thanks a lot. I do hope that it's been useful. So in such case, you just need to focus on the quality rather than look for a problem with genetics then, yeah?
That's correct.
Okay. And possibly this is our final question. So already I would like to thank everyone for joining us tonight, for your questions, very detailed ones sometimes. So I hope that it was useful for you. I do believe it was. And of course, as always, Dr. Garcia, it's always great to have you back. As you know, it's our, I don't know which one, webinar with you. So it's been always amazing to cooperate with you. So thank you so much, not only for today, for always being out there with us and helping out. And well, remember, you can get in touch with Dr. Garcia and her team at Clinica Tambre in Madrid. And I'm happy to be here. So again, I'm looking forward to our next webinar with you. And before we finish, is there anything you would like to add?
That's it. Always a pleasure to talk with you, to have these webinars and help people, okay, to achieve their dreams.
Exactly. So we are always here to support you. And well, I always say that, let's stay positive, and we definitely are keeping our fingers crossed for your happy announcements and happy positive outcomes, of course, as well. So have a lovely evening, everyone, and I do hope that it's been useful for you. Remember, it has been recorded, so you will be able to find it on our YouTube channel. It will be available on our myivfnss.com website as well. So thank you so much. Enjoy your evening, Dr. Garcia. I know that we will see each other very, very soon. Thanks a lot so much, and have a lovely evening as well. Thanks so much. Take care, everyone. Bye.